Moving on to management techniques for the problem list. The first management technique is education on positioning for her shortness of breath at rest. I would recommend use of a seated position with a forward lean. As the patient is less mobile and short of breath, I'm assuming they're spending the majority of their day sitting or laying. In a seated position, I would advise them to sit leaning forward with their elbows resting on a table. They could even have a pillow down so they can rest their head. It can be utilized just for comfort, and I would then instruct them to breathe normally until their shortness of breath is gone. For the next problem, I would recommend using active cycle of breathing technique. That's going to help with volume loss and sputum retention. So I would recommend use of this technique as it incorporates breathing control, thoracic expansion, and a huff. As this can be done in any position, it's beneficial for the patient since their mobility is vastly reduced. We'd start with breathing control. I would instruct the patient to breathe. I would demonstrate first, and then I would instruct the patient. So just going to move on to instructing them. I would instruct them to breathe gently to their normal volume and at a normal rate. I'd recommend placing a hand on their stomach to remind themselves to diaphragmatically breathe so they can look down and see their stomach raise and not their chest, their upper chest especially, as well as the shoulders. After they're relaxed and completed breathing control, I'd move on to thoracic expansion exercises. This is done by taking a deep breath in with emphasis on slow inspiration through their nose. I'd also add in a 2 to 3 second sniff and hold if they were able to do so. After this, I would move back to breathing control to allow for some recovery from fatigue and any breathlessness they may have felt. I would repeat this cycle for 2 to 3 sets. Moving back to the thoracic expansion, I would do the slow breath in through your nose 4 to 5 times with the 2 to 3 second sniff and hold. Following the 2 to 3 sets of the breathing control and the thoracic expansion, I'd recommend a huff, which is done through exhalation of an open mouth and throat instead of a cough. This technique will help to reduce work of breathing, increase lung volumes, as well as reduce any sputum retention that they may have. To decrease the effects of exercise intolerance, I recommend pacing. Start by recommend try and mobilize independently or with the help of a carer, and to plan accordingly. That means to have the safety precautions in place. As their baseline was a 10-meter walk and they're no longer at baseline, I'd probably recommend sit to stands to start. As long as there is a chair available in case they feel weak or lightheaded, they're easily able to get down to the chair and safe as well. Following that, I would have them plan ahead if they start to mobilize moving back towards their baseline. So if they're starting to take more steps, whether it be 5 meters, working to that 10 meters, I'd make sure that they have some sort of mobility device or chairs around that where they're able to rest. In case of needing it, I'd recommend adopting a forward-leaning position as well to relieve any sense of shortness of breath in case they did have to take that rest. Moving on to the physiological rationale for the techniques just mentioned. Found a study by Campbell, 2011. The study was designed to provide an evidence-based approach to management of dyspnea, shortness of breath. Specifically, there's no one best position for a patient to be in to relieve shortness of breath, but it is patient-specific. So, as there's no mention of unilateral lung damage, COPD, for this patient, it appeared to be bilateral, as there was also bibasal reduced air entry. I decided to use a seated position as it's advantageous to both lungs, opposed to, say, a side-lying position, which would only be advantageous to the lung that's upright. Moving forward to the positioning and how important the positioning is. The positioning would help alleviate the shortness of breath feeling, but also improve respiratory muscle function, which is important because of the accessory muscle use that they have been experiencing. So as the forward lean posture improves the length tension relationship of the muscles, specifically the diaphragm, they're able to work more effectively and efficiently for the patient with less effort. So furthermore on that, it also reduces secondary muscle activity, specifically in the scalenes, sternocleidomastoid, and also makes the thoracoabdominal movements more efficient. This is very important as the patient feels short of breath at rest, and this can help alleviate some of these symptoms. Moving forward onto the active cycle of breathing technique, a paper by Shen et al. 2021. They support the use of the active cycle breathing technique for sputum production. However, their study did also look at if active cycle breathing technique changes the sputum viscosity. There was no data to support that. However, ACBT demonstrates no adverse events among COPD patients. The study also demonstrated an increase in forced expiratory volume and arterial oxygen saturation as well. This is important because we know that the patient is having a hard time clearing the sputum that they may have in their lungs, especially at the base. So a greater forced expiratory volume would allow them to get some more secretions out of their lungs. And we also know that they have reduced oxygen saturation. So improvements in oxygen saturation would be beneficial for the patient as well. So when looking at the rationale behind the ACBT, active cycle breathing, when looking at breathing control activates parasympathetics, so it's going to help the patient to relax. It's very useful in between bouts of thoracic expansion exercises and the huff as well, as it allows recovery from the expected fatigue we would especially see in this patient since they're so short of breath. It also prevents oxygen desaturation because they're able to calm themselves down. Prevents bronchospasm if they do have, because they do have COPD, we know their bronchioles are already constricted, so going into spasm would only make it much more difficult for them to breathe. And of course, it also relieves breathlessness, which is one of the symptoms our patient exhibits. Moving on to the thoracic expansion exercise. The deep breath in through their nose is going to maximize alveolar interdependence, and the sniff would help with surfactant redistribution. This is beneficial as the patient has reduced air entry bibasally, so a deep breath will allow for that thoracic expansion deep into the lungs, into the lower lobes, help fill the alveoli at the base, as well as the sniff will help with surfactant redistribution to help open up the alveoli. I would recommend doing this for 4 to 5 sets for maximum benefit. Moving on to the huff, this would help with sputum retention and specifically sputum clearance. The huff is more beneficial than, say, a cough, as it subjects the patient to less transpulmonary pressure, which could lead to some sort of bronchial spasm or collapse as well. Identifying and justifying the short and long-term goals for this patient. To start with the short-term goals, first one being educating them on the importance of exercise to increase the tolerance for completing their activities of daily living. Independence is very important to them, and especially the aging population. So teaching them the importance of staying active even if they don't feel like it, and the importance of carers coming in and helping them, how that's going to be beneficial long-term in maintaining some sort of independence would be important. Secondly, improve the feeling of dyspnea at rest is another short-term goal. This is timely. We can teach them how to do that by changing positions. As mentioned, the forward lean position, it's not a very difficult thing to teach. And as I said, it's timely and measurable. You'll be able to decide if you're feeling better or not within a few breaths, hopefully. Moving on to the long-term goals, I'd like to implement a physical activity plan to improve mobilizing in activities of daily living, and also move back towards their independent mobility, which was the baseline of 10 meters. So as previously mentioned, I would maybe start with sit-to-stands with a chair behind them, and moving forward, we'd like to progress that into the 10-meter stand, or 10-meter walk, sorry. This is measurable because the patient will be able to see progress, specific, because we're going from sit to stand, which they're not very mobile at the moment. It's attainable, I believe. Hopefully the meds they're taking and with the interventions, there'll be a regression in their symptoms and they'll start to feel better. Time-wise, I'd like to see this start to happen in about 2 weeks, but understanding that they've been in the hospital, this is their second admission in the last 2 months, this may take some time. So 2 to 4 week window would be ideal for that to start to happen. The other thing is I'd like to increase their outdoor mobility. However, I think for that to happen, there would need to be a discussion for a railing to be installed, because safety would be the first priority. So if they're not safe to go down the front steps, they won't be able to practice outdoor mobility with their 4-wheel walker. That's also very important because it gives them more mobility outside and more independence, being able to move about outside instead of just in the home. Again, that all relies on the fact of getting a outdoor railing and, of course, them even wanting to progress with that.